Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome. Thank you for joining us for this episode of our ASCO recap. I'm Aly-Khan Lalani, joined by my co-host, Christopher Wallis. We're on our last day of ASCO 2024, Chris. Been a bit in a mix of weather, sunny and rainy. How have you enjoyed ASCO so far?
It's always a great opportunity to catch up with friends, catch up with colleagues. We've got a beautiful sunny Monday here in Chicago, so going out on top.
Yeah, I love it. So this will be our renal episode. We're kind of hot off the press of the renal oral sessions. And for a bit of a one list for our viewers and listeners, we're going to cover this portion in an adjuvant setting, talk a little bit about what we learned more to help refine patient selection. Then in the metastatic setting, we've not had new clinical data, but we have had a little bit of new understanding from some correlative work, biomarker work. And then if time permits, we'll get to some potpourris from a rapid orals that we think might be relevant for our population. So to kick things off, let's start adjuvant. Chris, why don't you level set the framework of what the current clinical aspect of adjuvant therapy for RCC is from your viewpoint?
Absolutely. And I think, it's nice to have a historical perspective here, right? We know that patients with, high risk, localized, or more sort of locally aggressive tumors may be cured with local therapy, but may also have a relatively high recurrence rate. And so for decades now, we've been trying to find some systemic options that really offer these patients a benefit. And the mTOR TKI story was played out and really not very successful. And I think the last few years we've had a bit of a revolution here with the introduction of IO. We've got 5 trials. Really only one that's driving our clinical practice to date. And so, I think most people make our decisions based on the pembrolizumab data. And obviously that was presented with OS data at GU ASCO. And we have a great recap on all that data from back in January. But the takeaway, I guess, from my perspective is for patients who have resected localized kidney cancer with these high-risk characteristics, T3s, T4s, node positives, sarcomatoid in particular. These patients, from my perspective, really deserve a discussion about adjuvant pembrolizumab. We have a variety of other trials, which unfortunately didn't show benefit to other IO-based treatment regimes. And I think that fits into the whole mindset of how we need to think about adjuvant therapy, right? Adjuvant therapy is inevitably going to result in some degree of overtreatment, right? We're trying to treat a patient population, some of whom are already cured by surgery, some of whom are destined to develop metastatic disease regardless of what we do. And there's that sweet spot in the middle where we're trying to identify patients who aren't cured by surgery and have that opportunity to cure them with some adjuvant, a finite duration of adjuvant systemic therapy. And so I think, the idea here of being able to enrich that patient population and really identify those who are going to most benefit from that systemic adjuvant therapy so we can spare those who don't need it and really, I would say, increase the value proposition of the use of adjuvant therapies.
Yeah, and to your point, one of the challenges we have is we know inherently there's some overtreatment coming for patients who will be cured with surgery alone. And so what we did, I think, learn at ASCO 2024, a nice presentation led by Laurence Albiges on behalf of the team, the EMOTION trial looking at adjuvant atezolizumab for resected RCC, which our viewers and listeners probably know was a negative study. However, as is the theme in kidney cancer, we learn a lot even from negative clinical studies from the biomarker work. So I would say our first real takeaway has been this KIM-1, a kidney injury molecule, essentially a glycoprotein that is circulating as a tumor-associated protein. And the data today was to show at the oral presentation, did we learn from this biomarker? And really briefly at a high level, there's a couple of things. One, this is a blood-based biomarker that can be assessed in plasma or serum, which is helpful. Part of the analysis is trying to understand, is there a high and low definition? And if it is, what have we learned from that? And, really, this is a first foray. And so part of it is a trial in itself. We'll use a cutoff or a median time point to understand what high and low is as a cut point. So if we assume that we think we know what high and low is, this data showed that, first of all, for patients at baseline, so after nephrectomy, entering a trial, high KIM-1 levels in the blood were associated with worse prognosis, which I think is important at the kind of time point of starting treatment. And what it actually showed specifically was that those who had really high versus low, the high levels had a DFS of about 36 months, let's say about 3 years, whereas those who had a low level, would have had a higher DFS of just under 57 months, around 5 years. So there's this concept that perhaps it might be prognostic. And then perhaps there's, in comparing it to the placebo arm, some predictive component to that. So I think it's a really encouraging first pass in kidney cancer. We haven't really had a good blood biomarker. Lots of questions that still remain to refine it. But to me, it's really the first time we've had a really good pass at saying there's something in the blood potentially definable that we can use to understand how these resected kidney cancers behave. And to your point that we led with, inherently in an adjuvant era where we're treating with IO, admittedly different treatment with pembrolizumab, can we refine better? Where do you see that future of KIM-1 going? I mean, I think we're just scratching the surface. There's some questions that remain. What was your kind of takeaway on that?
Yeah, so I mean, I think there's a huge clinical promise here. We obviously need to better understand how to use this biomarker. Is this going to be something like a PDL1 or a CPS where you have some finite binary cutoff, you're above or below 1%? Are we going to set some concentration of KIM-1 that drives our decision making? Do we acknowledge that this is, really a continuous variable? And you can think of many markers in oncology, CEA, PSA for the GU space. There's a lot where we can use continuous operationalizations of these tumor markers. And so knowing how to use it, I think is going to be one barrier we need to get over. But there's a variety of clinical contexts I think you're alluding to that we can really leverage it, right? Immediately post-op, we can think about risk stratifying our patients better beyond the clinical nomograms we have today to understand who's at high risk of recurrence versus not. And then even within that, understanding whether this is something we can intervene on. Is this something that, adjuvant therapy is going to modify that risk or not? And then, the third option really is for monitoring, I think. Right, so be able to serially test this in the way that we would, for example, in a PSA after radical prostatectomy or after local radiotherapy as an early serologic marker for recurrence before there's radiographic evidence. Now the question is that actionable? We're going to need to learn that. But the other one thing I think we took out of the discussant around this is that this is not a clear cell specific marker, and I think that's a really interesting opportunity for us because all of our adjuvant data to date has been clear cell restricted. And I know we were discussing, offline, there's huge unmet needs for patients with papillary and chromophobe. And so the opportunity that gives us a renal cell, not just a clear cell renal cell biomarker, I think is a really nice aspect to this story.
Yeah, and as you say, it will need validation. This was done in a trial that essentially is not informing practice, but we might learn from this. And so can we dig deeper into what is high and low? I agree with you. We haven't defined that. Is it going to be a continuous variable like someone's PSA? And really what we want to know is, can we understand if you have disease after a kidney cancer surgery? Can we follow it to know quicker than scans as to when cancer is back? And can that help us decide treatment after? And if we get there, that would be exciting. And the biomarker world for kidney cancer has been challenged by a lot of this over the years. But this is really, really an encouraging first pass. And I think from a research standpoint, if this is truly stable, and if the tubes that we need to capture this aren't overly complex, shippable, not too much transfer requirement between labs and clinics, then I think this can be something we can easily study, because that's the next pass, is to make sure we can study this in investigator or industry-led trials. So I think from a adjuvant therapy, that was really a big takeaway from today.
Yeah, I think you're highlighting maybe some of the issues with biomarker studies that we've been maybe exploring more historically in the more advanced kidney space. And I think that's maybe an easy time to switch to two other abstracts we saw at this morning's orals. again, diving into notions of biomarker and treatment selection, this time in first-line metastatic disease. We saw data from CLEAR, data from Keynote 426. This builds on data from another atezolizumab trial, or a couple of them. How do you try and contextualize what we saw from the biomarker studies in the metastatic space here?
Yeah, I mean, a lot to summarize here, and we'll try and keep it brief. But as you said, we had the CLEAR study looking at lenvatinib and pembrolizumab versus sunitinib. And then right after that, we had presentations on pembrolizumab and axitinib versus sunitinib from the Keynote 426 trial, and their first pass or deeper forays into biomarkers. And I think at a really high level, and there's lots of innovative work happening, tried to understand is something like PD-L1 status, which we think matters in cancer. Potentially, we thought in GU cancers it would be helpful. What about gene expression, signatures of angiogenesis or more immune infiltration? Can they help us discern if there's a better way of selecting treatment for our patients? I think really at a high level, what we found is that much like the clinical outcome, rather reassuringly, the combination treatment appeared to benefit over sunitinib in patients who had evaluable, tumor tissue largely, regardless really of the signature or PD-L1 status. There were some interesting findings to say that perhaps we know that there are some signatures for patients within a, for example, sunitinib group. Within that patient population, the ones who are likely to benefit perhaps are more angiogenically driven, which again, we've thought about for some time. And as you mentioned, came from the atezo-bev frontline trial. Again, not a combination we use day to day, but very helpful signatures that are building the framework of how we do further biomarker work in RCC to help us understand why patients might benefit from Sutent alone. But I think the gap still is to say, well, are we sure that that signature we can simply say is attributed in a clinical IMDC good risk? And then make the step point to say, well, that means it's probably driving the outcomes in good risk patients who got Sutent in all these trials. I'm not sure that's a straight line. I think it certainly explains why some patients are benefiting from Sutent. But as observations were made, and again, we're just hot off the press from the presentation, inherently these trials, both arms had a TKI in there. So while it may explain within arm benefit, it doesn't really help us discern differences, but it is clearly showing, in these large randomized phase 3 trials, we're trying to understand biomarkers better. So, certainly a lot of great work to dig deeper into. Certainly when we download the slides, look deeper, see the papers, it will help all of us to try and understand what biomarkers we should be looking at in ongoing trials that, for example, have just completed. We're looking at developing analysis. So I think that's where we'll take some learnings away. But for now, I think the take home is 2 drugs in first-line kidney cancer largely have preserved clinical benefit and no biomarkers discriminating that just yet.
Absolutely. And I think it helps us maybe understand the disease a little more, but not understand our treatment choices necessarily.
Yeah, speaking of treatment choice, we did see, and we should mention, one of the final frontline trials to have a so-called final analysis of overall survival. Do you want to take us through the axitinib avelumab study and kind of what we can take away from that as to whether it informs our practice?
Yeah, so we're talking about Javelin Renal 101 here. One of many trials looking at an IO-TKI doublet compared to sunitinib in the first line setting. The data has been out for many years now, showing a PFS benefit, and this was Dr. Motzer presenting the final pre-specified overall survival analysis. To date, while deemed immature, OS has not really shown us convincing outcomes. And I think what we see here really reiterates what most have seen before, which is that overall survival, while the curves do show slight benefits for the combination arm in a way that we would expect, these don't reach either clinically meaningful or statistically significant thresholds. I think Dr. Porta put it very well as he used the grade sort of approach to try and evaluate the veracity of the data here. We have wide confidence intervals, including potentially pretty meaningful clinical benefits, or also absolutely none. And so we can think about absolute risk differences, something in the range of an average expected benefit of like 4 in 100 patients, but opportunities to consider reasonable outcomes ranging from 9 in 100 benefiting to 1 in 100 being harmed. And that really puts us in that context of it not being really on par, I would say, with the data we've seen from other trials. And so when you go to clinic next week, how does this fit into your treatment armamentarium?
Yeah, and at least in North America and Europe, largely, it's been a PD-1 based backbone if we're looking at combination treatment. So it wouldn't change what I would do. I think it was important to have these readouts. Look, patients participated and their families did, and we need to, I think, show that final outcome, which was important. But I think it was very aptly put that in light of the crowded landscape, I think it would be inappropriate to say this is a standard of care in the same footing as other combinations. So I think if there are guidelines out there that perhaps had historically copy-pasted axitinib, avelumab into options, I think you could see the hint from discussant would be to say, it wouldn't inform my practice. Our ESMO guidelines don't have this. And in general, it probably shouldn't be what we kind of teach people to think about in kidney cancer, whether it's patients or trainees or other doctors getting into it. So I think that was at least nice to see, important to show, especially when we have patients, and a large number of them, commit to trials. The other way of looking at our oral session was also on a known IO-TKI like nivolumab and cabozantinib, and trying to apply really a partitioned overall survival outcome using something like treatment-free survival. And just very briefly, we have seen that the Checkmate 214 data, the analysis led by Meredith Reagan, but also a host of 214 leadership on that trial, took a leap of faith to show us this treatment-free survival that we now know well, where patients start on a treatment or on that treatment with and without toxicity. There's perhaps a gap between getting to the next treatment, and that gap might have with and without toxicity that's being recovered. And then, there's a subsequent treatment, and how long do patients stay on that, realizing that subsequent treatment is a bit of real-world data. And, so that's really the context behind treatment-free survival, and perhaps understanding beyond just progression, if patients are taking a pause on treatment, how are they living life? And in general, the IO has largely been double what the monotherapy TKI arms in those trials have been. And there were some data showing TKIs were the same as the combination component for treatment-free survival. I think this data showed there was perhaps some improvement on the order of, maybe 2.4 months for treatment-free survival with Nivo Cabo versus Sutent. But I guess one of the questions is, when that is really drilled down to only 0.7 months without toxicity, it's a balance between saying perhaps that wouldn't inform my choice of combination, but it's still an important endpoint to look at future trials. I mean, that would be really the nutshell takeaway. I mean, how do you view that moving forward as we think about endpoints for trials?
Well, I mean, I think it's important to take a little step back, right? When you think about what a patient wants, they want to live long, but they also want to live well. And so I think this is a metric of trying to get a sense, it complements a variety of other studies. I think we also need to do a better job on patient-reported outcomes. And this, feeds into that, but it's another metric of capturing that living well component of surviving. And so, I think if we think in the context of this analysis, we have 4 years of data, 48 months. If we're talking about a 0.7 month difference, we're talking, something in the order of like 20 days spread out over 4 years, where you are off drug, not experiencing toxicity. Like, is that a meaningful difference? You leave it up to an individual patient to decide, but this isn't like life-changing, I don't think. But I do think it's an important measure for us to be considering. And I think to some degree, this difference here between what we see from these data and from 214 really reflects the fact that the TKI needs to be ongoing in the doublet arm here, whereas with the IO-IO combo, you do have that opportunity to go on like true treatment holidays.
Yeah, that, 2 drugs of induction followed by 1 drug once a month for maintenance, especially if there's pauses in treatment-free intervals. Interestingly, I think we all have, again, it's anecdotal experience from clinic, but the treatment-free survival might even be longer with some of these combinations, especially nivolumab and ipilimumab in our real-world clinic, inherently because there isn't a TKI component, countered by better response rates with the TKI doublet. So I'm not sure it would change exactly how we talk to patients about making a choice. It might, but I think it might help give confidence to say if you are needing a treatment holiday for whatever reason, there is some confidence that that might be beneficial, and yet we can restart therapy thereafter. As we're about to wrap up this first session, we might do a quick hitters. Chris, a couple that stood out to me from the rapid orals as we wrap up kidney cancer here. We had a nice IMDC analysis, which many of us, including Canada, participated in, looking at the favorable risk population. And really the big takeaways, and I encourage folks to look at the presentation, was that we see there might be some favoring of TKI-based therapies for endpoints like response or time to next therapy, but in general, overall survival looks quite similar for the favorable risk for all the options, including IO. And it comes back to a podcast we just had, and I invite our viewers and listeners to see the one that we had with Dr. Misoel from MD Anderson, looking at stats design. But really, my takeaway is that it would have been nice, given the ITT populations of all these trials benefited all patients, that we would have options of all doublets for our patients, so IO and IO-TKI for favorable risk. That's my own take. But I think really the IMDC work showed that there's a group that's very favorable, meaning not a lot of poor prognostic locations, no liver or bone mets. The time from diagnosis to treatment is more in the 3 years and beyond. These very favorable patients, it does look like a TKI-based regimen, ideally doublet, seem to benefit those and be very important. Limited numbers, but it's really helping us further refine, I think, that so-called good risk patient or favorable risk patient into almost very good or very favorable. The last one that I take away, I think, is variant histology. So there's a nice, nearly 100 patient analysis of chromophobe RCC. And it's funny, we have patients in clinic. I had them just last week with chromophobe RCC looking for data on how we approach these patients. And again, most of our trials are all clear cell driven. But this analysis showed that for chromophobe RCC, largely patients who had doublet regimens, so in some cases IO, but largely IO-TKI and maybe even TKI-mTOR inhibitor, like lenvatinib and everolimus, did better than patients who got a mono-targeted therapy alone. Largely that's a mono-TKI. I think the real takeaway is we have more data that in chromophobe patients, we should try to get doublets in if there's a way to get them IO-TKI, TKI and mTOR, and then a salvage TKI as potentially 3 lines of therapy for chromophobe RCC. I think that's the takeaway for clinicians watching to say, hey, how do I approach these patients? And luckily, we do have data from some of these trials that did look at non-clear cell or build around non-clear cell to further give us evidence, realizing there's always small numbers. So I think from a rapid oral session, that was a nice takeaway. And, again, we have a lot to cover in other sessions, but it was a nice kidney day overall, wouldn't you say?
Yeah, I think, we didn't have the big splashy phase 3 trial this year at ASCO, but in spite of that, I think we were able to get some useful data and things that help us really advance the care of our patients. And so I think we're wrapping up now kidney cancer. Feel free to join and check out our other episodes focused on bladder and prostate. And we thank you again for joining us on the VONGU. On behalf of my co-host, Aly-Khan Lalani, I'm Chris Wallis, and we'll see you next time.